Good afternoon, judges. I'm Atchapa Ploynumpol, and today I'll be presenting our systematic review and meta-analysis on the oculomotor biomarkers for the differentiation of Parkinson's disease and atypical Parkinsonism. A preliminary data. But first, huge acknowledgement to my advisor, Assistant Professor Special Dr. Jirada Singan. Idiopathic Parkinsonism is a progressive neurodegeneration syndrome prevalent with increasing incidence. This includes Parkinson's disease and its mimic, atypical Parkinsonism, such as the progressive supranuclear palsy, multiple system atrophy, and the dementia with Lewy bodies. These conditions share numerous overlapping motor symptoms, so early and accurate differentiation remains a major clinical challenge, with a lack of biomarker as a distinguisher. But the eyes may hold the answer because the oculomotor system maps directly onto the specific brain circuits, offering a promising window into the underlying degeneration. And with the increasing research supporting as such and no prior research has synthesized the available evidence, our goal is to identify the ocular characteristics that could function as early, accurate, and non-invasive biomarkers for distinguishing Parkinson's disease from atypical Parkinsonism. We follow PRISMA 2020 guidelines and search from two databases, PubMed and Scopus, from inception to August 2025. We include observational studies that quantitatively measured at least one oculomotor parameters, including the saccades, smooth pursuit eye movement, vestibulo-ocular reflex, fixation stability, lid control, and nystagmus, with direct between group comparisons between Parkinson's disease and at least one atypical Parkinsonism. Data were extracted and the risks of assessment were assessed using Newcastle-Ottawa scales. In total, 31 studies were included for the systematic review and 11 studies met the criteria for the meta-analysis. And this is our results. We finalized our ocular biomarkers in help differentiating between the progressive supranuclear palsy and Parkinson's disease, the multiple system atrophy and Parkinson's disease, and the dementia with Lewy bodies with the Parkinson's disease. So first, to differentiate it between the progressive supranuclear palsy from the Parkinson's disease, 6 ocular features are consistently reported. First, the slowing of vertical saccades. The rapid eye movement that shifts the point of fixation is slowed in PSP. In our meta-analysis, the vertical saccadic peak velocity was significantly lower in PSP. Second, the saccadic hypometria, or the undershooting of the target, is shown by a significant reduced amplitude of the vertical saccade in PSP. The elevated anti-saccade error rates are found in PSP patients, although the findings were mixed, but one reported a strongly significant increase, meaning PSP patients make more incorrect eye movements when instructed to look away from the target. Next, the vertical smooth pursuit gain was more consistently impaired in PSP patient, meaning when following a moving object, the eye moves too slowly and cannot match the target speed. Next, markedly increased square wave jerks is found in the PSP patient with a significant mean difference of square wave jerk frequency. So, in PSP patients, when fixated, the eyes repeatedly drift away and jerk back to the center. Last, the supranuclear lid dysfunction or the eyelid abnormality incidences are found more in the PSP patient. Now, to differentiating between multiple system atrophy and Parkinson's disease, 3 ocular features are consistently reported, being more common in multiple system atrophy. First is the catch-up saccades, which means the eye moves too slowly and falling behind a moving target, so small saccades are needed to catch up the target. Next is reduced reflexive saccadic velocity, which means a reflex-driven saccades triggered by a sudden target is slowed in MSA. And the last one is the gaze-evoked nystagmus, which is when looking to the side, the eyes drift back and snap forward repeatedly. We conducted a meta-analysis for all the 3 features and found the pooled odd ratio, indicating significantly higher odds of catch-up saccades in MSA patients, along with the reduced reflexive saccadic velocity, showing a significant odd ratios. The gaze-evoked nystagmus is more frequently observed in MSA patient, while absent or nearly absent in Parkinson's disease patient. Now, for the differentiation between the dementia with Lewy bodies and the Parkinson's disease, only one study was available, but it shows that dementia with Lewy bodies patients have markedly impaired reflexive saccadic execution, slower, less accurate, and more error-prone, distinguishing them from the non-demented PD with a specificity of over 88%. Now, as the oculomotor pathway are tightly linked to a specific neuroanatomical circuits, eye movement acts like a virtual biopsy of the discrete brain regions. For example, the vertical saccades rely on the rostral IMLF and the interstitial nucleus of Cajal cell. Both are affected early in the course of PSP. So the vertical saccade impairments might suggest and support the PSP. For MSA, our results reveal a completely different oculomotor phenotype of the gaze holding and pursuit, corresponds to the dysfunction of the cerebellar flocculus and the pontine gaze holding networks, which are selectively affected by the alpha-synuclein deposition in the MSA. Therefore, the oculomotor impairments map directly onto the known topography of the proteinopathies, providing a clue to the differential diagnosis. And although these single biomarkers may show a high diagnostic value with high specificity, the sensitivity is low to moderate. Therefore, the next step is to shift from a single parameter evaluation toward a composite oculomotor diagnostic index combining multiple features. This could pave way for non-invasive, inexpensive diagnostic tools that improves early differentiation between Parkinson's disease and atypical Parkinsonism. In summary, the finding of this research supports the feature of future development of quantitative oculomotor findings as a practical clinical diagnostic tool. Thank you very much for your attention.
May I ask your question about how the studies gather the patients? Usually, they compare two set of people on the parameters of the nerve conduction, right?
The nerve conduction
between... Sorry, the parameters on oculomotor, right? What kind of participant that they choose for their inclusion and exclusion criteria?
For the exclusion, they choose the diagnostic of Parkinson's disease and atypical Parkinsonism based on the diagnostic criteria of MDS criteria, and for the dementia of Lewy body, different from other, being the McKee 2017, and then they do the video oculography and other method of ocular measurements.
And how did they pick the control? Do they pick the normal control or?
Yes, they picked the normal control, but in here the inclusion criteria is the direct between group comparisons between Parkinson's disease and at least one atypical Parkinsonism. So I do not include the information that we compare with the control.
So you compare only between the Parkinson and atypical Parkinson's, right? On
Yes.
the oculomotor parameters.
Yes.
So in the end, what kind of implication from the result that you have? So you mean because you only select only these two set of participants, right? So you want this test to differentiate between the patient with Parkinsonism and atypical Parkinsonism. Am I correct?
Yes.
And may I know why you pick this problem?
Because the differentiation between Parkinson's disease and atypical Parkinsonism is a major clinical challenge because they share a lot of overlapping motor and non-motor symptoms. And the differentiation is important because it guides the prognosis and the treatment. As the main treatment of Parkinson's disease, as you know, is levodopa. But for the atypical Parkinsonism, they do not respond to levodopa. And the prognosis is way more rapid and the prognosis is poorer than the Parkinson's disease. So it is important to early differentiate between the two. And also for some who was diagnosed with Parkinson's disease and do not respond to levodopa, this diagnosis should be considered as well.
I have no question, just quick recommendation. Based on your research question, I would like to see the sensitivity and specificity. I mean, for the pool sensitivity and specificity using the oculomotor measure rather than the proportion difference between these two.
Okay. So
Maybe
from
in the future you can conduct another meta-analysis to combine this kind of diagnostic measures for this kind of research question.
thank you very much for your suggestion.